Hello everyone from the 175th Annual American Psychiatric Association Conference. We're here filming for Medscape and Columbia Psychiatry. We wanted to give you an update on eating disorders. So I'm here with a good friend and colleague at Columbia Psychiatry, a psychologist, a researcher, clinician, Deb Glassifer. She's been in our department for as long as I've been in our department. And you are really my go-to expert when I'm struggling with one of my patients trying to do a better job treating eating disorders. And so I just wanted to start there, Deb. What are some of the things that psychiatrists, how can we do a better job in terms of screening, in terms of helping patients with eating disorders?
Well, first, thanks so much for having me and for asking me to answer some of these questions. I love helping psychiatrists learn sort of more questions to ask their patients about how to better assess these kinds of problems. So what I find when people are coming to me for a specialized assessment, some of the questions they feel like I ask them that they haven't been asked before would be things like what kinds of rules they're following about their eating, what their general eating pattern is like, what their psychological experience around eating is. Do they feel guilty or ashamed or out of control when or after they eat? I often ask people a little bit about their weight history. I will ask about if they tell me that they've used certain drugs, whether they might be using those to impact their appetite.
What kind of things?
For example, stimulants, for example. Either stimulants that have been prescribed or something like cocaine if their kid has used that recreationally.
And how do you, when you have a patient come in who's underweight or you're concerned and it's not the topic of discussion, how do you get started?
When I'm concerned about weight?
Mm-hmm.
Well, sometimes I'll even start with, it might depend on what their kind of presenting complaint is. So I know that when people are generally undernourished, things like anxiety tend to go way up, mood tends to go way down. And so usually there is a way in with some symptom that is bringing them into the door to connect that and ask if they've experienced any change in weight lately. And sometimes that's a way to kind of get there.
I feel like I haven't updated my eating disorder knowledge since residency. And have there been some changes or advances in terms of diagnosis or things that we should know about, those of us who maybe aren't as updated
who
as we should be?
Who aren't reading the DSM-5 every single day? Sure. So binge eating disorder, first of all, should be said, which was considered sort of a putative diagnosis in the appendix in DSM-4, has moved into the feeding and eating disorder section in DSM-5, well-researched, well-recognized. There's also a diagnosis now called avoidant restrictive food intake disorder.
Okay.
Catchy, ARFID for short.
ARFID, okay.
And this is really, a lot of research is pretty interesting being done to better understand who these individuals are. But as defined in DSM-5, these are folks who are having a lot of difficulty nutritionally or weight-wise due to restrictive eating. They might be restricting because of textures of food, colors of food, because of a fear of nausea or vomiting, and they're running into a real kind of functional impairment because of their restrictive eating. But these folks do not have body image concern. They're not afraid of getting fat. They're quite motivated to gain weight. They're just very afraid of eating a wider array of foods that would help them to do so. And as I said, there's a lot of research going on right now to understand whether this is a broad diagnosis is sufficient, or are we actually talking about different groups of people who land here for different reasons.
Just shifting gears a little bit, a lot of us in clinical practice are getting so many questions about food and diet, and there's so many different types of diets and eating plans. Mm-hmm. Are there certain ones that are red flags for you, or are there certain things that we should be screening in terms of how patients are engaging in different types of plans for their eating? Mm-hmm.
So I learn the most about different diets from patients who come in and tell me a story that starts with a diet that they've come on. So I don't know in particular a diet to flag. But I think in general what's important to understand is that there should be flexibility to eating, and that even if someone feels it's important to follow certain principles or guidelines in what they're eating, that there should be really a malleability so that it isn't hard to grab a meal on the go, even if you're at an airport that doesn't have, food where all of it's sourced. You should be able to eat dinner with your family, even if that means there's going to be something processed in the meal. So that's the main thing that I'm sort of helping people to think about, rather than saying like absolutely no to this, absolutely no to that, are the general principles of normal eating. You know, if you're a vegetarian, okay, are you able to get all the nutrients you need that way? Are you able to sustain a weight that is psychologically and physically healthy for your body? Great. If not, if vegetarianism was a step on the way to eating an extremely restrictive diet, to losing weight, to a very unhealthy physical and psychological state for you, well then maybe that's something that needs to be addressed as part of a treatment plan. But really depends on the individual and the type of eating problem they're experiencing.
Well, thank you for all of those updates. I think something that you've helped me with and to encourage all of you is to simply remember to screen and when we find disorders like eating disorders, to refer to our colleagues who are specialists in that to help us get our patients fully well. So Dr. Glassford, thank you for joining us.
Thanks for having me.
We'll see you next time here on Medscape Psychiatry.